Hello students. Welcome to the chapter Concepts of Care for Patients with Non-Inflammatory Intestinal Conditions. And right now we need to talk about colon cancer. Okay, so let's start. Let's watch a video first to understand much better this condition. Okay, colorectal cancer. Okay, here we go.
Colon cancer, commonly grouped together with colorectal cancer, is cancer of the large intestine, the final portion of the digestive tract. It is the most common of all gastrointestinal cancers. Colon cancer usually starts from a small growth called a polyp. Polyps are very common, but most polyps do not become cancers. Polyps can be of various types, some of which are more likely to develop into malignant tumors than others. Early-stage colon cancer generally produces no symptoms. Advanced stage symptoms vary, depending on the location of the tumor, and may include changes in bowel habits that persist for weeks, blood in stool, abdominal pain and discomfort, constant feeling that the bowel doesn't empty completely, fatigue, and unexplained weight loss. Early detection is the key to prevent colon cancer. Because a precancerous polyp usually takes years to develop into a malignant tumor, colon cancer can be effectively prevented with regular screening. There are two major types of screening tests. Stool-based tests. Stool samples are examined for signs of cancer, such as blood and mutated DNA. These tests are non-invasive, but less effective and need to be done more often. Visual screening, such as colonoscopy, is more reliable and can be done every 5 or 10 years. Colonoscopy uses a long, flexible tube equipped with a camera and light to view the entire colon. If polyps or abnormal structures are found, surgical tools are passed through the tube to remove polyps or take tissue samples for analysis. Typically, any polyps found in the colon are removed during colonoscopy and examined for precancerous changes, known as dysplasia. If high-grade dysplasia is detected, a follow-up colonoscopy is required to monitor the condition. Colorectal cancers are caused by mutations that increase the rate of cellular division. Some of these mutations can be inherited from parents. Examples of inherited colorectal cancers include familial adenomatous polyposis, or FAP, a condition caused by mutations in the APC gene. The APC protein acts as a tumor suppressor, keeping cells from growing and dividing too fast. Mutations in APC result in uncontrolled cell division, causing hundreds of polyps to grow in the colon. FAP patients usually develop colon cancer by the age of 40. Lynch syndrome, another inherited condition caused by changes in genes that normally help repair DNA damages. A faulty DNA repair results in increased rate of mutations. Patients are at high risks of colorectal cancer, as well as other types of cancers. In most cases, however, the mutations that lead to cancer are acquired during a person's life, rather than being inherited. The early event is usually a mutation in the same APC gene that is responsible for FAP. While FAP is a rare condition, APC mutations are very common in sporadic colorectal cancers. Apart from genetic predisposition, other risk factors for colon cancer include aging, high red meat and low-fiber diets, obesity, alcohol use, smoking, diabetes, and inflammatory intestinal conditions such as ulcerative colitis and Crohn's disease. Thank you for watching. If you like our videos, be sure to check out our new Patreon page.
Thank you very much. Always Alila Medical Media has great videos, really well explained. Okay, so basically we saw a good description of the condition and also genetic risk factors. as well as other risk factors. In summary, colorectal cancer, which is diagnosed in early stages, is curable. Okay, so the problem here is to promote preventive screening and suggest and advise the patient to have a healthy nutritional diet. Colorectal cancer to the colon and rectum, which together make up the large intestine, also known as the large bowel. Colorectal cancer, which we are going to call right now CRC, is cancer of the colon or rectum. Okay, so the colon, ascending colon, transversal, descending colon, or rectum. In the United States, it is the fourth most common malignancy, and second most common cause of death, second most common cause of death-related death among adults. Patient often consider the diagnosis of cancer as a death sentence, but colon cancer is highly curable for many patients, especially if detected early, as we mentioned before. Pathophysiology: tumor occur in different areas of the colon, with more than half occurring within the rectosigmoid region. Half occurring in the rectosigmoid region. Most CRC are adenocarcinomas. The increased proliferation of the colonic mucosa form polyps that can become malignant tumors. As we saw in the videos, it takes several years for that benign polyp to become malignant. Okay, so it's the proliferation of the colonic mucosa. Most CRC and the mucosa, is due to prolonged chronic inflammation. Obesity is a chronic inflammation. Okay, so if you are obese, then the chronic inflammation, chronic mucus formation is going to develop polyps. Most CRC are believed to arise from adenomatous polyps that present as a small growth covered with mucosa and attached to the surface of the intestine. It couldn't be better explained. So here we have the diagram. We have the 30% is in the rectum, in the sigmoid colon. So if you add the 30% of the rectum plus the 25 in the sigmoid colon, there you go, 55% of most colon cancer are occurring in that area. CRC can metastasize by direct extension or by spreading through the blood or limbs. The liver is the most common site of metastasis from circulatory spread. Metastasis to the lung, brain, bones, and adrenal glands may also occur. Colon tumors can also spread by peritoneal seeding during surgical resection of the tumor. Seeding may occur when a tumor is excised and cancer cells break off from the tumor into the peritoneal cavity. So that's good to know. Seeding must be considered before surgery. You need to educate your patients about this, and so they can further ask more questions to the surgeon about this possibility. Okay, the major risk factors for the development of colorectal cancer include age, older than 50 years. Hello, that's good to know. Genetic predisposition, as we saw in the video, right? The familial adenomatous polyps, and then the Lynch syndrome, and or personal or family history of cancer. However, recently an increasing number of adults under 50 of age are being diagnosed with CRC. Why is this happening, right? Because why is this happening? All of us, we are having a healthy diet. It's weird, right? It's very weird. Without a clear cause. Some diseases also predispose the patient to cancer, such as familial adenomatous polyposis, the one we saw in the video, Crohn's disease, ulcerative colitis, and Lynch syndrome. That's good to know. Don't postpone screening, especially if you or anybody in your family had colon cancer. You need to start your screening earlier. Genetic genomics, people with first-degree relative, parent, sibling, or child diagnosed with CRC have a 3 to 4-fold increase in the risk of developing the disease. Many genes are associated with CRC, an autosomal dominant inherited genetic disorder known as familial adenomatous polyposis, the one we saw in the video also, and also the Lynch syndrome. And you can go over this information to get more details. Lynch syndrome, also known as hereditary non-polyposis colorectal cancer, is another autosomal dominant. And here you go. I'm not going to test you on the mutations, so this is for general information. The most important is that you need to know that we have this familial adenomatous polyposis, FNP, and if you have genetic risk or anybody in your family having Lynch syndrome, then your screening should be early. Having said that, the genes, okay, there are many patients that I know with genetic risk, but for the gene to develop the same disease, you need to provide the environment, okay? So you need to have a diet that is not healthy. Maybe you're having high cholesterol, maybe diabetes. So if at certain point there is a prevention in all these factors, okay, and the patient is having a healthy diet, is doing exercise, is not having a sedentary life, is not eating fast food, getting good amount of fluids, not drinking alcohol, non-smoking. So the formation, the development of that gene is going to be delayed. Okay, so it's basically that you don't give the environment to the gene to develop. Okay, so some lower GI cancers are related to Helicobacter pylori, which we studied in deep in the previous chapters, Streptococcus bovis, and human papilloma virus. There is also strong evidence that long-term smoking, obesity, physical inactivity, and heavy alcohol consumption are risk factors for CRC. We just mentioned that. Please, I want you to remember this. That's good to know. This is NCLEX alert, especially smoking, obesity, physical inactivity, heavy alcohol. There you go. You have the three of them: smoking, obesity, alcohol. The physical inactivity is a risk factor, but common factors shared in different diseases, especially cancer, are having the origin in smoking, alcohol, and obesity. A high-fat diet, particularly animal fat from red meats. Recently, the American Cancer Society made a statement about the red meat, okay, and the relation with cancer. They are carcinogenics. Finally, they recognize it. Even the processed red meat, okay? So this red meat increases bile acid secretion and aerobic bacteria, which are thought to be carcinogenic for the bowel. Okay, thank you. Diets with large amounts of refined carbohydrates that lack fiber decrease bowel transit time. So this is a concept that we need to master. If we eat excessive carbohydrate, then the transit time, the bowel movement is going to be delayed. That's why it's better to get fresh, raw vegetable and fruits. This predisposes individual to polyp formation. So the carbohydrates, especially think about your diabetic patients and the risk they are going through. So meeting healthy people 2030 objectives, colorectal cancer, the most important is to reduce the colon cancer rate and increase the proportion of adults who get screened for colorectal. Health promotion, disease prevention, teach patients whose family members have had hereditary CRC to get genetically tested for familial FAP and Lynch syndrome. If genetic mutations are present, the person at risk can collaborate with the PCP to decide which prevention or treatment plan to implement. So that is going to depend if the patient is having comorbidities, additional risk factor like diabetes, high cholesterolemia, hypertension, atherosclerosis, obesity, you name it, okay? Okay, so the Healthy People 2030 initiative recognizes the need for additional attention to the reduction of new cases of cancer and cancer-related illness, disability, and death. Teach adults about the need for diagnostic screening. Be aware that screening rates are lowest among uninsured and uneducated, less than high school education adults. Although I've seen many patients that are not having insurance, health insurance, they are willing to pay out of pocket for this screening. There are many of them, okay? But still, you need to promote and teach. When adults turn 40 years of age, they should discuss with their primary healthcare providers the need for colon cancer screening. So here come nurses, our voluntary work. So there are many patients, probably many people you know, I know, that they don't have health insurance, and they know that probably their immigration status is not complete in this country. But we know them from the church, we know them from different places, right? Community places, maybe from the library. We can offer our services to educate patients in these places. Is something that is going to, we're going to feel very, very happy, and is very rewarding to promote voluntary patient education. So we as a nurses, is our commitment not only to provide care for people that are in hospital, nursing homes, but also to the community that is in need. Okay, that's part of our duties as well. The AC screening options include stool-based testing. Okay, ACS, American Cancer Society screening, includes stool-based testing, including fecal occult blood, FOT, and multi-target stool DNA. All these tests in detail were explained in the chapter, in the introductory chapter of gastrointestinal related to the assessment. I also included videos for this, okay? So please, that's good to know. Go to that chapter and watch all the videos that are there available for you. You don't have to do nothing, just click the video, play the video, and see all the, or you can open the supplemental material which has the links related to specific data that you want to access. Okay, screening for colorectal cancer not recommended for individuals who are older than 85 years due to the risk associated with cancer treatment. As a result, for those over 85 who are diagnosed with CRC, surgeries withheld. Remember the seeding factor we mentioned before. Screening for those between 75 and 85 of age is optional depending on predicted life expectancy. So it all depends on the prognosis, okay? Basically, you want to provide comfort, a comfort life, a nice, how can I explain this to you? You don't want the patients over 75 or 85 to go through surgery, chemotherapy, radiation. You want to provide a good time. It's the end of their life, so you don't want to cause traumatic events at the end of the life, right? Teach adults, regardless of risk, to modify their diets as needed to decrease fat, refined carbohydrates, and low-fiber foods. Obesity is a major risk factor for most types of cancers. As I explained to you, it's a chronic inflammation. Obese patients are living in a state of chronic inflammation. Encourage baked or broiled food, especially those high in fiber and low in animal fat. Remind adults to eat increased amount of vegetables, including, this is the most important part of this lecture, I will say, broccoli, cabbage, cauliflower, and sprouts. Anti-cancer-aging vegetables, right? Antioxidant. Okay. Broccoli. cabbage, cauliflower, and sprouts. I understand that previously in intestinal obstruction, I mentioned to avoid this broccoli, cabbage, cauliflower, and flour because during obstruction, these vegetables are going to cause gas, okay? For that particular intestinal obstruction, we are going to avoid this one. For prevention, colon cancer, even during treatment, the benefits of broccoli, cabbage, cauliflower, and sprouts is very well known. Okay, you can eat your broccoli, steamed broccoli, you can prepare broccoli souffle, broccoli soup, you can eat it just baked with some sauce on the side, the same with cabbage, the same with cauliflower and sprouts, okay? Educate about the hazards of smoking, excessive alcohol, and physical inactivity. We spoke about that, and that's good to know. Patient care, healthy equity. The 5-year survival rates are lowest for Black individuals. Please make sure you remember this. I've seen in the exam many of you thought that the higher risk in the population with the higher risk of CRC is Asian Americans, and it's not that. It's Black individuals, okay, especially those under 50 years of age. When compared to all other racial groups, mortality of 30 to 40% higher among residents of poor regions, including those in Appalachia and parts of South and Midwest. Okay, so think about this. Lack of access to CRC screening, lack of health insurance, low formal education, less than high school, and lack of innovative cancer care are also factors that we need to address. That's why I always say that if we were lucky and blessed enough to have the opportunity to study, we are supposed to give back to the society. So we can volunteer in church, in community places, maybe in senior healthcare facilities. We can teach them, okay? And this is part of our nursing duty. Okay, so assessment. Ask the patient about vomiting, bowel elimination habits, constipation, or change in shape of stool with or without blood. Fatigue also is going to be another symptom related to anemias, abdomen, because probably the patient is going to be bleeding. Not really a heavy bleeding, but if you have a patient that is bleeding a little bit for a long time, then this is going to be an anemia. It's going to become an anemia, okay? Abdominal fullness, back abdominal pain, or unintentional weight loss. These symptoms suggest advanced disease. Again, if you have a patient with an intentional weight loss, okay, that means that the patient is going to tell you, you know, I lost 15 pounds in the last 2 months, right? So that's something that you need to pay attention. The most common sign of rectal bleeding, anemia, and change in stool consistency of shape. These are symptoms of CRC, okay? The stools may contain microscopic amounts of blood. I just mentioned if you have a little bleeding for a long time that are occult, hidden, or the patient may have mahogany, dark color, or bright red stools. Gross blood is not usually detected with tumors of the ascending colon. Listen to this. This is a very important part. Gross blood is not usually detected with tumors of the ascending colon, but is common but not massive with tumors of the descending colon and the rectum. I'm going to repeat it. Gross blood is not usually detected with tumors of the ascending colon, meaning the tumors that are located between in the cecum, right, where the ascending colon starts, right, when the ileum ends. But it's common, gross blood is common, but not massive, with tumors of the descending colon and the rectum. Okay, that's good to know. So tumors in the transverse and descending colon result in symptoms of obstruction. Tumors in the transverse and descending colon result in symptoms of obstruction. The patient may report gas pains, cramping, or incomplete evacuation. Tumors in the rectosigmoid colon are associated with hematochezia, the passage of red blood via the rectum. Hematochezia, the passage of red blood via the rectum. Straining to pass stools and narrowing of stools. Patient may report dull pain. Now, right-sided tumors can grow quite large without disrupting bowel patterns. Right-sided tumors, okay, that is the ascending part, can grow quite large without disrupting bowel patterns or appearance because the stool consistency is more liquid in this part of the colon. Think about it. The only activity the colon does is to absorb fluids. That's the only thing the colon does. Peristalsis, absorb the fluids, and with that peristalsis is pushing the content, right, the feces, to the sigmoid and the rectum to be eliminated. That's the only thing the colon does. So the tumors, the stool consistency is more liquid in the part of the colon in the right side, meaning in the ascendant, because still that's the part of the colon that is receiving the content from the ileus, right? The ileum, sorry, from the ileum. So in that part, the absorption of fluid is partial. It's just the beginning, the ascending. Okay, that's why the stool consistency is more liquid in this part. These tumors ulcerate and bleed intermittently. Consequently, the stools can contain mahogany dark color blood. A mass may be palpated in the lower right quadrant, and the patient often has anemia secondary to blood loss. Okay, so there are different assessment tools, assessment tests to differentiate between appendicitis, which is in the right lower quadrant, right? And many patients may think, oh, I have appendicitis, when in fact, maybe there is a formation of a tumor in that part. Okay, so we can see these common causes of lower gastrointestinal bleeding. Lower gastrointestinal bleeding. We see the hemorrhoids, the rectal cancer, diverticulosis or diverticulitis, which are little pouches, and we're going to talk about that later. Then we see the colon cancer. We see the polyps. Okay, those are not pouches like diverticulitis. These are polyps. These are really small masses, right? That we know they are the origin is mucus, right? And then little by little they start degenerating, and through the years they are going to convert into malignant. Ulcerative colitis, we have these little ulcers here. Okay, laboratory assessment, a positive test result for occult microscopic blood in the stool, the FOBT, fecal occult blood test. We have all the tests that you already need to be familiarized since the first chapter of GI, which is assessment. A few extra information. The test can yield false positive result if certain vitamins or drugs are taken before the test. We are talking about the fecal occult blood test. So aspirin, vitamin C, iron, and red meat need to be held for 48 hours before giving a stool specimen. Also assess whether the patient is taking anti-inflammatory drugs like ibuprofen, corticosteroids, and salicylates. Please remember, I figured out some students at this point in the program, they don't know the relationship between ibuprofen, and gastrointestinal area versus acetaminophen, Tylenol, and the liver. Okay, so Tylenol, acetaminophen affects the liver, and ibuprofen affects, which is an NSAID, affects the gastrointestinal. This is very important, and it's not possible that in this semester we are still explaining this. Okay, also corticosteroids. Okay, you need to know the side effects and the consequences of prolonged use of prolonged use of corticosteroids. Please, for the FOBT, 2 or 3 separate stool samples should be tested on 3 consecutive days. Negative results do not completely rule out the possibility of CRC. Carcinoembryonic antigen CEA on an oncofetal antigen is elevated in many people with CRC. Okay, carcinoembryonic antigen, the CEA. Now, the normal value of this oncofetal antigen is less than 5. This protein is not specifically associated with CRC, and it can maybe be elevated in the presence of other benign or malignant diseases and in smokers, okay? So probably a smoker can have an elevated CEA and maybe does not have any masses, any malignancy, okay? CEA is often used to monitor the effectiveness of treatment and to identify disease recurrence. This is very important, to identify disease recurrence, okay? That's good to know. NCLEX alert when they ask you, because there are different markers, okay? Different tumor markers that we're gonna study through this semester until the end, especially when we get into the breast cancer markers, okay? So this is one of them. Now, other diagnostic assessment, CT-guided virtual colonoscopy is a less invasive option for colorectal imaging. It is thought to be more thorough than traditional invasive colonoscopy. However, biopsies and surgeries cannot be performed when a virtual colonoscopy is used. And let's watch a video about the CT colonography so you can have an idea. It's a very good tool, but biopsies cannot be done when we have this procedure. Okay.
A CT colonography is a test to look at the inside of your bowel. Your bowel needs to be empty for the test, so you have to follow a special diet for a couple of days beforehand, usually a low-fiber or liquid diet. You'll be given instructions about what you need to do. Before the test, you take a laxative, or a special liquid called gastrographin. This is a dye to help make the scan clearer, but also works as a laxative. You will have diarrhea, so it's best to stay at home close to a toilet. On the day of the test, you can continue to drink clear fluids up to a few hours before. The radiographer puts a small tube, called a cannula, into a vein in your arm or the back of your hand. You may have the drug through this cannula to relax your bowel muscles. This reduces cramping during your test. You may need to have an injection of X-ray dye through the cannula. This helps to show the other organs outside of the bowel. You then need to lie on your left side, and the radiographer will put a small tube into your back passage to pump air or carbon dioxide inside your bowel. This helps to open up the bowel to make it easier to see it on the computer. You may feel as if you need to go to the toilet or to pass wind. It is normal, but try to keep in as much gas as you can. You then have 2 or 3 CT scans in different positions. All of your images will be looked at using a special computer program. This shows up any growths or abnormal areas on your bowel wall. After the test, you may feel bloated, have stomach pains, and pass wind. This doesn't last long. To make sure you're okay, you usually stay in the department for 20 minutes. Then you can go home and eat and drink normally again. You usually get the results within a couple of weeks from the person who sent you for the test.
Thank you very much. So you see another difference between CT colonography and colonoscopy is that you are turning into different positions, right? So this is not happening in colonoscopy. In colonoscopy, you are positioned on the left side, and then the endoscope will enter, and you will stay in that position through the entire procedure. Right here, no, you are going to be asked to turn into different positions. So during the sigmoidoscopy, which is the colonoscopy, also they can do they can remove polyps. Polyps can be visualized and tissue samples can be taken for biopsy. Okay, and colonoscopy is the definite test for the diagnosis of colorectal cancer. Please supplemental material in chapter 45 for colonoscopy. There are videos there. Now, interventions. The primary approach to treating CRC is to remove the entire tumor or as much of the tumor as possible to prevent or slow metastatic spread of the disease. Now, with this removal, also several adjuvant additional therapies are used. Therapies are administered before and after the surgery, and that depends on the location, the stage, and the decision between the patient and the surgeon, okay, and the oncologist, what they are going to do. Non-surgical management, the type of therapy used is based on the pathologic staging of the disease, as I just mentioned. The staging system used most often in colorectal cancer is the TNM, so it's tumor, nodes, metastasis. Tumor, stage 2, 4 lymph nodes involved, metastasized, let's say, to the liver. Okay, so that is the classification. Preoperative radiation therapy has not improved overall survival rates for colon cancer, but it has been effective in providing local or regional control of the disease. So preoperative radiation has not improved overall survival rates for colon cancer. This information right here is very important for you to teach the patient or even family members. So when they are going through a disease similar to this, you need to discuss with them, hey, I learned that radiation in this case has not improved overall survival rates, so it's up to you, you want to do it or not. Okay, but it has been effective in providing local or regional control of the disease. Post-operative radiation has not demonstrated any consistent improvement in survival or recurrence. However, as a palliative measure, radiation therapy may be used to control pain, hemorrhage, bowel obstruction, or metastasis to the lung in advanced disease. For rectal cancer, unlike colon cancer, radiation therapy is often a part of the treatment plan for rectal cancer. Okay. Adjuvant chemotherapy after primary surgery is recommended for patients with stage 2 or 3 colorectal cancer to interrupt the DNA production of cells and destroy them. So the common agents used for this is intravenous 5-fluorouracil with leucovorin, capecitabine, irinotecan, hydrochloride, and oxaliplatin. So therefore, common side effects are diarrhea, mucositis, leukopenia, and we know what it is. In the first week, we learned leukopenia, yeah, related to all the leukocells, right? Which are the white blood cells. Mouth ulcers and peripheral neuropathy. Some patients report that complementary and integrative therapies, including cannabis, are useful to minimize these side effects. Bevacizumab is an angiogenesis inhibitor, also known as a vascular endothelial growth factor inhibitor, and approved for metastatic CRC. So let me make a parenthesis here. all tumors need a vascular system to get food and nutrients for this. So immediately after the creation of a tumor, these little monsters are going to create a network of vascularity around to get the food. So the bevacizumab is an angiogenesis inhibitor, angio related to vascularity, genesis. So this is a generator of vascularity inhibitor. It's going to inhibit the creation of that vascularity in order to how can we call it, to starve, to create the starving process for that tumor. Do not get feeding. Okay, this drug reduces blood flow to the growing tumor cells, thereby depriving them of necessary nutrients need to grow. Exactly. So then cetuximab and panitumumab are monoclonal antibodies known as epidermal growth factor receptor inhibitors, and may also be given in combination with other drugs for metastatic disease. These drugs work by blocking factors that promote cancer cell growth. So you have the endothelial growth factor inhibitors, which are going to be the angiogenesis inhibitor, right? They are going to be the ones that are going to stop the creation of vascularity. And you have the epidermal growth factor receptors, which are going to where they are going to block factors that promote cancer cell growth. It's two different approaches, okay? One is vascularity, the other one is working in the multiplication of these cancer cells. Intrahepatic arterial chemotherapy, often with 5-fluorouracil, may be administered to patients with liver metastasis. Patients with CRC also receive drug for relief of symptoms such as opioid analgesics and antiemetics. Okay. So now, surgical management, surgical removal of the tumor with margins free of disease is the best method of ensuring removal of CRC. So removal of the tumor with margins free of disease. So they are going to remove the tumors, some lymph nodes around that may be having the condition, and also some tissue around that is healthy, that does not have any disease. Factors help to determine the surgical approach for CRC. These include the site of the tumors, its location, the extent of metastasis, integrity of the bowel, and condition of the patient. During surgery, a number of lymph nodes are removed and examined for the presence of cancer. The number of lymph nodes that contain cancer is a strong predictor of prognosis. Yes. So the more lymph nodes are involved, the stage of the tumor is going to be high. It's not going to be a stage 1, maybe stage 2. Plus, remember, we are going to use the classification TNM, the tumor, nodes, and the metastasis. Okay, the most common surgeries performed are colon resection, removal of part of the colon and regional lymph nodes with reanastomosis. Means that after they remove that part of the colon, they are going to unify. They are going to unify the end and the beginning of the other part, right? Then we have partial colectomy with a colostomy, temporary or permanent, and then we have total colectomy with an ileostomy, ilioanal pull through, and abdominoperineal resection. So for this, I selected a video so we can understand much better. Okay, it's always good to watch a video for better understanding.
Surgical management of colorectal cancer is highly dependent on the location and nature of the cancer itself. And whilst you don't need to know the specific ins and outs of each of the surgeries, just having a good idea of the types of operations we perform and the locations which are relevant to them is really important. So moving quickly through these, In those patients who have a cancer in the cecum, ascending colon, or proximal transverse colon, we'd perform a right hemicolectomy. In those patients who have a more distal transverse colon cancer, or a splenic flexure cancer, we'd undertake an extended right hemicolectomy. In those patients in whom the cancer is localized to the left side colon, we'd perform a left hemicolectomy. A sigmoid colectomy would be our treatment of choice in patients who have sigmoid cancers. And in those patients who have a cancer that's located in the rectum, we'd perform an anterior resection, with the resection of the distal colon and part of the rectum, and anastomosis between these two free ends. In those patients who have an extremely low or distal rectal cancer, or who have an anal cancer, we'd perform an abdominal perineal resection, or APR, in which we'd remove the anus, the rectum, and the sigmoid colon, and we would then create a permanent colostomy, as well as suture close the perineum. In those patients who have multiple or synchronous tumours, which is found to be the case in approximately 3 to 9% of cases, then we carry out a more extensive resection of the large bowel by performing either a subtotal colectomy or a pan-proctocolectomy. If you enjoyed watching this video, then make sure you subscribe to our YouTube channel for more great...
Thank you. Wow. This was an excellent video. I don't have any question. It's so clear. A colostomy is the surgical creation of an opening, stoma, of the colon onto the surface of the abdomen to allow passage of stool. An abdominal perineal resection, which is shown in the video, is performed when rectal tumors are present. In this procedure, the surgeon removes not only the sigmoid colon, but also the rectum and the anus through combined abdominal and perineal incisions. Okay, remember the abdominal perineal resection because we are going to talk about this more in depth in the next minutes. Minimally invasive surgery via laparoscopy is a common surgical approach, and for this, the stay in the hospital is going to be shorter, fewer complications, and it's fast healing. Preoperative care reinforces the surgeon explanation of the planned procedure, the location and number of incision sites and drains. You need to explain this to the patient. Before evaluating the tumoral color during surgery, the surgeon may be unable to determine whether a colostomy or less commonly a ileostomy will be necessary. So colostomy is going to be when the stoma is in the colon, and ileostomy is when the stoma is in the small intestine, right, which is less common. The patient is told that a colostomy is a possibility. So what they are explaining here is that until the doctor, the surgeon, is able to see the damage in the lumen, in the colon itself, the doctor cannot take a decision in advance before the surgery if the patient is going to need a stomach colostomy or not. Okay, the doctor needs to see. The patient is told that a colostomy is a possibility. Okay, the surgeon consults a certified wound, ostomy, and continence nurse. Certified wound, ostomy, and continence nurse to recommend optimal placement of the ostomy. They are specialized in, depending on the patient's body, if the patient is obese with distended abdomen, if the patient is skinny, the different activities that the patient perform, where is the best place to put the stomach, right? The patient who requires low rectal surgery, the abdominal perineal resection, We remove the sigmoid, the rectum, and the anus. It's faced with the risk for postoperative sexual dysfunction and urinary incontinence after surgery due to nerve damage during surgery. Yes. Teach the patient about the method of pain management to be used after surgery, such IV patient-controlled analgesia, epidural analgesia, or other method. If the bowel is not obstructed or perforated, elective surgery is planned. If the bowel is not obstructed or perforated, elective surgery is planned. The patient may be instructed to complete a bowel prep to minimize bacterial growth and prevent complications. Mechanical cleaning is accomplished with laxative and enemas or with whole gut lavage. Give me 2 minutes, please. Let me close the window. Okay. And then, so mechanical cleaning is accomplished with laxatives and enemas or with whole gut lavage. The use of bowel preps is controversial and some surgeons do not recommend it. For example, older adults may become dehydrated from this process. You see the whole entire preparation in older adults. It's not only the preparation before surgery, but the risk of the surgery itself and post-operative, right? And the treatments that the oncology may want to start, chemotherapy, radiation. So sometimes it's not recommended to put these patients under those treatment, especially if they are above 95 years old. I had a case, very sad, of a lady, 92 years old, who received this chemotherapy. We, the nurses, were suggesting the doctor to stop the chemotherapies. There was, I think there were 12 rounds of chemotherapies prescribed, ordered, and the lady was having horrible side effects in the round 3. So we told the doctor to hold the chemotherapy until the patient, the lady, recover a little bit, right? So it was not done, and they keep administering the chemotherapy, and the patient passed away. 92-year-old. Sometimes it's not recommended to do this on elderly patients, right? So so for this type of surgeries, they are going to put IV antibiotics to be given. They're going to prescribe IV antibiotics before the surgical incision. NG tube is going to be in place for decompression. Peripheral IV or central venous catheter is also in place for fluid and electrolyte replacement while the patient is NPO after surgery. Patients who undergo minimally invasive surgery, meaning laparoscopic, do not need an NG tube, and that is common sense, right? So care, preoperative assessment by the certified wound, ostomy care nurse is going to analyze the key points of psychosocial assessment, the educational level, available support, the physical limitations. This is all the assessment the nurse is going to perform in order to suggest where the stomach could be placed. Key points: physical assessment, contour of the abdomen in lying, sitting, and standing position, presence of skin fold, creases, bony prominences, location of belt line. Believe it or not, this is important. Location that is easily visible to the patient. Of course, if you have a patient that is obese with the distended abdomen, you are not going to suggest the placement of the stomach on an area that is not going to be visible for this patient, right? Okay, operative procedures. For the conventional open surgical approach, the surgeon makes a large incision in the abdomen, tumor can be removed, a colon resection, the 2 open ends of the bowel are irrigated before anastomosis, okay? So a temporary or permanent colostomy may be created in the ascending, transverse, descending, or sigmoid colon. A loopstoma surgical opening is made by bringing a loop of colon to the skin surface, severing, and everting inserting the anterior wall and suturing into the abdominal wall. Loop colostomies are usually performed in the transverse colon and are usually temporary. Let's watch another video about stomas, okay? I hope you can get the opportunity to practice this in the open lab. That's a stoma. Different types: colostomy, ileostomy, urostomy, thank you so much. I love the music. Thank you so much. So you saw the type of stoma. An end stoma is often constructed usually in the descending or sigmoid colon when a colostomy is intended to be permanent, okay? So the least common colostomy is the double-barrel stoma, which is created by dividing the bowel and bringing both the proximal and distal portions to the abdominal surface to create two stomas. And we're gonna see a picture later. Laparoscopic colon resection or total colectomy allows complete tumor removal with an adequate surgical margin and removal of associated lymph nodes. Okay. Post-operative care. Here we go, the pictures, okay? Post-operative care, patients who have an open colon resection without a colostomy receive care like those having an abdominal surgery, period. We know abdominal surgery, we need to look and assess for signs and symptoms of infection, peritonitis. Okay, now, and they typically have a nasogastric tube, okay? A PCA pump for the first 24 to 36 hours. And after the GNT removal, the diet is slowly progressed from liquid to solid foods. Basic, that's basic. Now, by contrast, patients who have laparoscopic surgery can eat solid foods very soon after the procedure. They have less pain, are at risk for fewer postoperative complications. They can ambulate and heal early. That's the benefit, okay? So here we have some stomas. We have on the left, we have the ascending colostomy is done for right-sided tumors. Then we have the transverse double-barreled colostomy is often used in such as emergencies as intestinal obstruction or perforation because it can be created quickly. There are two stomas, and the proximal one closest to the small intestine drains feces, okay? And the distal stoma drains mucus. Interesting. And then we have the descending colostomy is done for left-sided tumors, and then the sigmoid colostomy is done for rectal tumors. Colostomy management. After a colostomy has been performed, assess the color and integrity of the stoma frequently. A healthy stoma should be reddish pink or direct to pink and moist and profuse about 1 to 3 centimeters from the abdominal wall, but most commonly about 2 centimeters. And this is good to know, okay? The color, reddish pink or dark red. That's good to know. I forgot. Okay? And now, during the initial postoperative period, the stomach may be slightly edematous. A small amount of bleeding at the stomach is common. These minor problems tend to resolve within 6 to 8 weeks. And that's good to know as well. NCLEX alert, okay? Let me play another video about the stomas. I came across this channel from John House, RN, nursing.com. I think she has very, very nice videos. So let's play one of them.
In this video, we're going to talk about stoma care. Now, the wafer and bag for an ostomy only needs to be changed every 3 days or if it's leaking, but you still need to be able to assess the stoma itself. So in this case, we're going to show you how to replace the bag and clean and assess the stoma. So you want to start by putting a towel under the patient on the side of the stoma. And then the first thing you want to do is assess the output from the stoma. So if you have a clear bag, you can actually see the output through the bag and visualize it that way. Otherwise, you'll need to empty it. In order to clean and assess the stoma, we have to remove the bag. So start by peeling the wafer and just pushing the skin down away from it gently. You might need to use warm water or alcohol here if the adhesive is tough. Now you want to clean the stoma and around it with a washcloth with warm soapy water. Just use gentle strokes. You don't want to scrub. Then you want to pat the skin dry with a towel. Again, don't rub, just pat. So now that the stoma is clean, you can actually do your assessment. So you want to inspect the stoma itself. It should be light to dark pink and moist. What you don't want to see is dark red, pale purple, or any kind of bluish color. None of those are good signs. They all represent problems with perfusion and should be reported right away. And of course, look for any skin breakdown. So now you want to measure the stoma and cut the hole of the wafer to be about 1/8 of an inch larger than the stoma. If it's too small, it can actually cut off circulation to the stoma itself. So you're going to use a pair of scissors to cut around the inside hole of the wafer. Now, some wafers, depending on the brand you have, some of them have little measurement tools, some of them don't. So just make sure that you are about 1/8 of an inch larger than the stoma itself. If you need to, apply skin prep or barrier to the skin around the stoma, and then remove the backing from the wafer and apply it to the skin with the stoma in the center of the hole. Now, for patients who've had a stoma for a long time, they may have a preference here of which angle they would like their bag going. Some of them like it going straight down, some of them like it going off to the side. So just make sure you talk to your patient about that. Now, as you're smoothing down the wafer, if you do get any creases that you can't smooth out, you can use a barrier paste to fill that in. If you're using a 2-piece system, apply the wafer first and then snap on the bag. Just make sure the bag is closed and sealed based on whatever type of bag you have. Discard your supplies, wash your hands, and document your findings. Make sure that you include this in output measurement as well. So that's it for stoma care. Remember, the little things might change depending on the type of stoma that your patient has and the type of bag device that they're using, but always look at the stoma and the skin around it. All right, guys, go out and be your best selves today. And as always, happy nursing.
Excellent, excellent. I love this channel. Very nice. Okay, so she explains about the assessment of the stoma and everything. Nursing safety priority, action alert, report any of these early post-operative stoma problems to the surgeon immediately. If there is a stoma ischemia and necrosis, in which case the stoma is going to be dark red, purplish, or black color, okay, dry, continuous heavy bleeding, mucocutaneous separation, breakdown of the suture line, securing the stoma to the abdominal wall. Assess the condition of the peristoma skin around the stoma, and frequently check the pouch system for proper feed and signs of leakage. Yeah, because that content, if it's leaking, is going to damage the skin around. You don't want to cause another infection or fungal, whatever. The skin should be intact, smooth, and without redness, hyperpigmentation, or excoriation. Monitor for common peristomal skin complications, including irritant dermatitis from fecal content, skin stripping from the adhesive barrier or water or wafer, and candidiasis, the fungal infection under the barrier or wafer. Okay, the one that I explained before. Okay, teach patient that the colostomy typically starts to function 2 to 3 days after the surgery. When it begins to function, the pouch may need to be emptied frequently because of excess gas collection. It should be emptied when it is 1/3 1/3 to 1/2 full of stool. Stool is typically more liquid immediately after surgery, but becomes more solid depending on where in the colon the stoma was placed. For example, stool from an ascending colon colostomy continues to be liquid, as I explained before. Stool from a transverse colon colostomy becomes pasty, and the stool from a descending colon colostomy becomes more solid, similar to stool expelled from the rectum. Perfect. Wound management. For an AP resection, do you remember the abdominal perineal resection? The perineal wound is generally surgical close, and 2 bulb suction drains, the Jackson-Pratt drains, are typically placed in the wound or throughout laparoscopic incisions near the wound. The drains help prevent drainage from collecting within the wound and are usually left in place for several days depending on the character and amount of drainage. So here we go, ladies and gentlemen. Here you have the Jackson-Pratt drains. Okay, let's watch this video.
In this video, we are going to look at how to empty a wound drain. Specifically, we're going to look at a Jackson-Pratt bulb drain, also known as a JP drain. So these drains help carry drainage away from the wound so they can heal faster with a lower risk for infection. So first things first, you're going to need a graduated cup or cylinder of some sort that will allow you to measure the output. Honestly, for small drains, urine specimen cups are my favorite go-to because I can put a lid on it when I'm done. So place a towel or an incontinence pad below the drain in case you spill or in case it splatters, which it does do. Then before you empty the drain, you want to actually inspect the drainage for its color, characteristics. Is it serous and clear, or is it bright red blood? Is it full of clots? Does it have pus in it? Now you can carefully open the port of the drain and turn it upside down to empty into the cup or container. You may have to gently squeeze the bulb to make sure that it is fully empty. Now, once you have the drain empty, you want to squeeze that suction again before you close the port. This is where we get that suction. Squeezing that bulb creates the suction inside the wound to help pull the drainage out of it. So if you need to, you can clean the port with an alcohol swab before you close it, just to make sure that it gets a good seal. Now take that graduated cylinder container, put it on a table flat surface, and look at it at eye level to measure the output. Once you have that output number, you can dispose of everything appropriately, make your patient comfortable, and of course, remember that you need to document the details about the output, what color it was, what consistency, and what the total amount was. One thing to remember is that if you do find the tubing has clots or blockages in it, you can gently squeeze or milk it, but never strip tubing like this, which stripping is putting it between your fingers and dragging your fingers down towards the drain. All that does is create excess suction, and it can actually cause damage to the wound. All right, guys, that's all you need to know. Make sure you know specifically how to manage whatever specific drain your patient has. If you aren't sure, ask someone. Now go out and be your best selves today, guys. And as always, happy nursing.
Okay, thank you so much. I love this channel. Definitely a good source of information. So we already presented the Jackson-Pratt. Monitor infection and abscess formation. Serous drainage from the perineal wound may be observed for 1 to 2 months after surgery. Complete healing of the perineal wound may take 6 to 8 months. Okay, the patient may experience phantom rectal sensations. You see? It's another type of phantom pain, right? This is a phantom rectal sensation because sympathetic innervation for rectal control has not been interrupted. So continually assess for signs of infection, abscess, and all these things that are common sense. Another NCLEX question. So the nurse is planning care for a client who returned from PACU after an abdominal perineal resection of a rectal malignant tumor. What would the nurse anticipate as the patient's priority problem? And the answer is not vomiting, it's not infection, it's not incontinence. The answer is pain, because the client have nausea and vomiting as a side effect of anesthesia, but not all clients have those symptoms, so choice A is not the correct answer. Infection and incontinence may occur later as complications, but would not be a priority immediately after surgery. So choices B and D are not. And clients have pain that is often difficult to control due to the high number of nerves that supply the perineal region. So is answer C. Okay, care coordination and transition management. The patient and family are faced with a possible alteration in body functions. Medical and surgical interventions for the treatment of colorectal cancer may result in cure, disease control, and palliation. So it's important radiation therapy or chemotherapy is typically administered on an ambulatory care basis. For the patient with advanced cancer, hospice care may be an option. So here you have a table recommending perineal wound care and what steps you need to be doing related to wound care. Maybe you want to use a feminine napkin as a dressing. Also, this is a section about comfort measures as prescribed, so the wound area in a sitz bath for 10 to 20 minutes, 3 or 4 times a day per day, or use warm compresses. This is perineal wound care, okay? Perineal wound care. Prevention of complications, your fluid and electrolytes imbalance, and monitor the incision integrity. Home care management. Home health visit by nurses or assistive nursing personnel can be provided. Ostomy products should be kept in the area, preferably in the bathroom, where the temperature is neither hot nor cold. Skin barriers may become stiff or melt in extreme temperatures, okay? So self-management education before discharge, teach the patient to avoid lifting heavy objects or straining on defecation, to prevent tension on the anastomosis site. If an open surgical approach is used, the patient should avoid driving and vigorous physical activity for 4 to 6 weeks while the incision heals. Action alert, nursing alert, attention, that's good to know, NCLEX alert, patient education. A stool softener may be prescribed to keep stool soft in consistency for easy of passage. Teach patient to know the frequency, amount, and character of the stools. Teach those with colon resections to watch for and report signs and symptoms of intestinal obstruction and perforation, like cramping, abdominal pain, nausea, and vomiting. Advise the patient to avoid gas-producing foods and carbonated beverages. So, for example, gas-producing foods are broccoli, are cabbage, are Brussels sprouts, right? So in this case, you advise the patient to avoid gas-producing foods and carbonated beverage because the disease already happened and this is post-surgery. So for prevention, when we are trying to prevent, we have to get broccoli, cabbage, sprouts, okay? The patient may require 4 to 6 weeks to establish the effects of certain foods on bowel patterns. Ongoing colostomy care, you plan sufficient practice time for learning how to handle, assemble, and apply all ostomy equipment. You need to teach the patient and the family members about appearance of a normal stoma and all the different characteristics that we explain through the chapter, including stool consistency. Patient with flat, firm abdomen may use either flexible, bordered with paper tape, or non-flexible full skin barrier wafer pouch systems. A firm abdomen with lateral creases or fold requires a flexible system. Patients with deep creases, flabby abdomens, are retract stoma, or a stoma that is flush or concave to the abdominal surface can benefit from a convex appliance with a stoma belt. So I'm just giving you a few explanations about the different types of stomas and the different types of pouches that are there in the market based on the body type. Measurement of the stomach is necessary to determine the correct size for the stomach opening on the appliance. The opening should be large enough not only to cover the peristomal skin but also to avoid stomach trauma. So skin preparation may include clipping peristomal hair or shaving the area, moving from the stomach outward. If you don't do that, whenever you are going to remove the pouch, you're going to hear the patient scream. To achieve a smooth surface, prevent unnecessary discomfort when the wafer is removed, and minimize the risk for infected hair follicles. Yes, that's something that sometimes we don't consider, but infection in hair follicles is a problem. Safety priority, teach the patient and family to use a skin sealant, preferably without alcohol, and allow it to dry before application of the appliance, colostomy pouch, to facilitate less painful removal of the tape or adhesive. Peristomal skin becomes raw skin striping, stomach powder or paste, or a combination may also be applied if the peristomal skin becomes raw. Control of gas and odor from the colostomy is often an important issue for patients with new ostomies. Reminds certain foods, such as vegetables, can cause flatus or contribute to odor when the pouch is open, and sometimes they are very uncomfortable. They don't even want to have family around them or close by. Even though if they are in their own rooms, the smell could pass through to different rooms. The patient should be cautioned not to put aspirin tablets in the pouch because they may cause ulceration of the stomach. Okay, believe it or not, this happens. Some patients, they put aspirin there. Okay, the patient with a sigmoid colostomy may benefit from colostomy irrigation to regulate elimination. However, most patients with a sigmoid colostomy can become regulated through diet. Irrigation is similar to enema, but is administered through the stomach rather than the rectum. And then psychosocial concerns. The patient's reaction to ostomy surgery may include fear of not being accepted by others, feelings of grief related to disturbance in body image, and concerns about sexuality. So a lot of psychosocial support must be provided. Home health care. The patient with a colostomy, we need to assess the gastrointestinal status, including the dietary and fluid intake habits, the weight gain or loss, presence or absence of nausea and vomiting, bowel elimination patterns, bowel sounds. Assess the condition of the stomach at least weekly, and you have to check for the location, the presence of peristoma hernia, pain or swelling, signs of ischemia. Assess peristomal skin for presence of absence or excoriated skin, fit of appliance, and effectiveness of skin variance and appliance. Assess the patient and family coping skills. This is the most important, I would think, because this is going to help in a faster recovery. Self-care abilities. Okay, so now you have a very nice evidence-based article about does colorectal cancer surgery affect sexuality. I invited you to read this. Healthcare resources, the ones that I saw here, I think these are amazing. Provide information about the United Ostomy Association of America, an advocacy group for people with ostomies. This is an excellent resource. The local division or unit of the American Cancer Society, cancer.org, can help provide necessary medical equipment and supplies, home care services, travel accommodation, and other resources for the patient who's having cancer treatment or surgery. Now, I want to tell you, American Cancer Society, they have a place called Hope Lodge, and they have different locations. This is a type of hotel that is providing housing, food, and all type of services from psychological services all the way to ambulance and transportation, and it's free. But the hospital in which the patient is being admitted or receiving the chemotherapy, and if the patient doesn't have any financial, it's not a good financial situation, they need to coordinate with the Hop Lodge in order, they need to provide how many chemotherapies the patient is receiving, the radiation treatments. But the most important is that the patient is to prove that at the end of the therapy, they are having plans on where to either travel back to their countries or move to another location with a family member. They need to have proof, so they need to make sure the patient is going to stay there forever. Okay, now inform the patient and family of the programs available through the local and division unit or division or unit. Another excellent source is cancercare.org. I highly recommend this website. They have also integrative, holistic approaches to cancer. Also, ccalliance.org, the National Cancer Institute. Basically, all these websites are excellent. Last question. The nurse is teaching a post-operative client about sending colostomy care. Which of the following statements would the nurse include in the healing teachings? Select all that apply. So, your stomach should remain reddish pink or dark red. So that's one. The stomach will shrink a little about 6 weeks after surgery. That's correct. And be sure to use a skin sealant before applying your appliance. So the rationale is an ascending colostomy would drain liquid stool that requires an appliance at all times. Yes, therefore choice C is incorrect. Any intestinal ostomy appliance need to be empty when it's 1/3 to 1/2 full to prevent leakage and improve comfort. Therefore, choice B is incorrect. Any stomach should appear dark red or reddish pink and will shrink in 6 to 8 weeks. So choices A and D are correct. And skin sealant applied before the appliance is added protects the skin and prevents irritation. So choice E is also correct. So with this, we finished the colorectal cancer part in this chapter related to non-inflammatory intestinal disorders. And when we come back, we are going to talk about irritable bowel syndrome. And if we have enough time, probably we're going to talk about some other conditions like abdominal hernia, abdominal trauma, like you see here. And also probably we're going to include hernias. And then, let's see, one more topic, I think hemorrhoids. And then, with that, we will finish this chapter. This is a very long chapter, but it's important, extremely important in healthcare. Thank you so much for your attention and stay tuned.